Welcome to our video on peripheral artery disease. Let's get started. Here's our overview slide. Let's begin by discussing the definition. This is an algorithm we'll be referring to for peripheral artery disease. Let's begin by discussing the definition. Peripheral artery disease is an atherosclerotic narrowing of the arteries in the legs, which leads to decreased blood flow and tissue ischemia. All right, now let's go over the relevant pathophysiology. Peripheral artery disease can be thought of similarly to coronary artery disease. An accumulation of atherosclerotic plaques leads to narrowing of the vessel, which leads to decreased delivery of oxygen-rich blood to the tissues. This decreased supply of blood is not sufficient to support the increased oxygen demand with exertion. The patient then experiences pain secondary to ischemia of the nerves and other tissues in the lower extremities, which presents as claudication. Here is a summary of peripheral artery disease pathophysiology. Atherosclerotic changes in the vessel walls, and specifically the deposition of plaques composed of calcium and fat, result in a narrowing of the vessel, along with an impaired ability to dilate in response to greater demand, and this results in tissue ischemia. There is overlap between the risk factors for peripheral artery disease and acute arterial occlusion, which we cover in another lecture. This includes smoking, diabetes, hyperlipidemia, and hypertension. Smoking is one of the most critical risk factors. All right, let's try a question. Why is smoking a risk factor for peripheral artery disease? Nicotine results in oxidative stress, which causes endothelial cell dysfunction and increased expression of adhesion molecules. This results in increased macrophage recruitment. The macrophages are then stimulated by the nicotine to secrete elevated levels of TNF-alpha, IL-1, and chemokines. These inflammatory changes lead to a necrotic core formation, which can contribute to the development of an atherosclerotic plaque. The interaction of the vasa vasorum with the nicotine leads to plaque instability, evidenced by the expansion to the intima, neovascularization, cell death, and plaque rupture. This is how nicotine can lead to the formation and rupture of atherosclerotic plaques, which, as we mentioned on the previous slide, plays a very important role in the development of peripheral artery disease. Patients with peripheral artery disease typically present with intermittent claudication, or pain in the legs after walking a specific distance. As we mentioned previously, this is due to the inability to meet increased oxygen demand with exertion due to decreased perfusion of the legs. Patients may also develop aching or burning sensations due to nerve ischemia and resultant ischemic neuropathy. Night cramps and discoloration of the legs are signs of a more advanced disease. This happens when perfusion decreases further and tissues are ischemic even at rest. An ankle brachial index is used to diagnose peripheral artery disease. It's a comparison between the blood pressures in the upper and lower extremities. We'll get into the diagnosis of various degrees of the disease after further explanation of the ankle brachial index. Here's a figure to help explain an ankle brachial index, or ABI. The ABI is calculated by dividing the higher systolic pressure of the respective leg by the higher blood pressure of either the right or left arm. Notice that instead of a stethoscope, a Doppler is used to assess the arterial blood flow. The blood pressure in the upper and lower extremities should be very similar, though not necessarily at the same time. This is why the normal range for an ABI is between 0.9 and 1.3. An ABI between 0.4 and 0.9 indicates mild to moderate disease with a good prognosis, while less than 0.4 indicates severe disease and a poor prognosis. At less than 0.4, patients generally experience pain at rest. All right, let's discuss a possible pitfall in using an ABI to diagnose peripheral artery disease. This is a histological cut of Monckeberg's arteriosclerosis, or medial calcinosis. This condition is an age-related degeneration of the blood vessels caused by calcium deposits in the vessel walls. As seen here, there is calcification of the medial layer of the artery, which causes rigidity. So when a blood pressure cuff is used, the cuff is unable to compress the artery and the ABI may be falsely elevated. This is possible in diabetic patients, so they can have readings of greater than 1.2 or just falsely normal. All right, now let's go through our approach to the diagnosis and treatment of PAD with the help of this algorithm. If a patient has peripheral artery disease risk factors like smoking, diabetes, and hyperlipidemia, combined with classic features such as intermittent claudication and discoloration of the legs, the ABI should be obtained to classify the severity, as this will determine the next steps in the management of the patient. If the ABI is between 0.4 and 0.9, the patient likely has mild to moderate peripheral artery disease, and conservative treatment is recommended. This consists of smoking cessation, graded exercise therapy, and treatment of the underlying conditions, such as hypertension, diabetes, and hyperlipidemia. Foot care is of the utmost importance as well, because this helps prevent infectious complications. If the ABI is less than 0.4, then the patient likely has severe PAD and will need an invasive workup, such as digital subtraction angiography, or DSA, as well as potentially invasive therapies like bypass grafting and angioplasty. Similarly, patients with mild to moderate disease who continue to progress and fail to respond to medical therapy may also become candidates for invasive imaging and treatment. All right, let's try another question. With what endocrine disorder would a patient likely have a falsely elevated ankle brachial index score, and why? All right, false elevations in the ABI come from calcification of the arteries, which causes the ankle readings to be falsely elevated. This is problematic because it can give the false impression that more blood is getting to the extremities that is in actuality. Calcification and hardening of the vessels is a common complication of diabetes, which is why Monckeberg sclerosis is more prevalent in this population. All right, now let's talk about the invasive treatment a little bit more. General techniques for surgical treatment include bypass grafting and angioplasty. Bypass grafting uses one of the patient's veins, frequently the saphenous vein, and creates an alternate route through a different vessel to supply the rest of the lower extremity. It's more invasive than angioplasty, which is why it's second-line treatment, but has a high success rate. Angioplasty uses ballooning with or without stenting, and this is the first-line treatment, but cannot be used in lesions below the knee. Here's an image explaining how angioplasty works. First, a catheter is inserted into the vessel past the site of the lesion. The balloon is then inflated to open the lumen. After that, a stent may be placed to help keep the artery open. All right, let's wrap up by finishing with a question. A 69-year-old male undergoes a procedure where a catheter is inserted into a vessel in his left and right lower extremities. A balloon was inflated and meshwork was then placed. What is a medication this patient might have been started on to help manage the main risk factor for his disease process? A. Fluoxetine, B. Rosuvastatin, C. Metformin, D. Bupropion, or E. Amiodarone. All right, the procedure described in the question is angioplasty with balloon dilatation and stent placement. Question writers expect you to know what the most likely diagnosis is based on the procedure performed. In this case, peripheral artery disease. The most significant risk factor for peripheral artery disease is smoking. On boards, it's common to have multiple steps in the question, so it's not enough to know smoking is the most significant risk factor, but also what can be used to help people quit. So a medication would have been started to try and help the patient quit prior to surgical intervention. Bupropion has been found to help people quit smoking, so D is the correct answer. Varenicline is another medication prescribed for smoking cessation. Fluoxetine is an SSRI, which is indicated in the treatment of anxiety and depression, but has no direct impact on smoking cessation, so A is wrong. Rosuvastatin is a first-line agent used in the treatment of hyperlipidemia. Hyperlipidemia is a risk factor for peripheral artery disease, but its impact is not as significant as smoking, so B is wrong. C is wrong for the same reason. Diabetes is not as much of a risk factor as smoking, which metformin is used to treat. Amiodarone is an antiarrhythmic with a high side effect profile with no utility in the treatment of smoking cessation, so E is wrong. You might think that this question is unnecessarily tricky, but on step 2 CK, you might need to pick the single most important risk factor for a particular pathology, and in the case of peripheral artery disease, it's smoking. So remember that, and that concludes this section.